So we have the next speaker now, Dr. Vijila, JANARDHANAN.
Good afternoon, everyone. My topic is biometric accuracy of refractive outcomes using Barrett Universal 2 formula in Holiday schema. It's not moving. Next slide. Okay. The most important factor affecting the refractive outcome of a cataract surgery is the IOL power, and hence the IOL power calculation formula. 1 millimeter variation in axial length can lead to change in the IOL power by 2.5 to 3 diopters. To the best of our knowledge, no study has analyzed the accuracy of Barrett Universal 2 formula in all the ocular geometries described by Holiday schema. So this is the Holiday schema, and the aim is to analyze the accuracy of refractive outcomes by Barrett Universal 2 formula in different ocular geometries by Holiday schema. Retrospective chart review of patients who underwent uneventful cataract surgery by phacoemulsification with in-the-bag intraocular lens implantation was performed in a tertiary eye care hospital over a period of 6 months. So inclusion criteria were like patients with age-related cataracts who underwent uneventful cataract surgery within an age range of 45 to 80 and amenable to optical biometry. The exclusion criteria included intraoperative complications and any prior ocular surgery, presence of any corneal pathology, and trauma or any other comorbid conditions. Ocular biometry was performed using optical biometer OA2000 by Tomei, and surgeries were performed by a single surgeon with a temporal 2.2 to 2.8 mm clear corneal incision by phacoemulsification, preoperative and postoperative refraction, uncorrected distance visual acuity, corrected distance visual acuity, and the IOL power implanted, predicted refractive error using for Barrett Universal 2 formula were recorded. The sample was divided into 9 categories based on the axial length to short, normal, and long, that is less than 21.6 mm, 21.6 to 25 mm, and more than 25 mm axial length. And based on the Y to weight, it was divided into small, normal, and large. The expected refractive error of the IOL implanted in each subgroup was compared with mean postoperative spherical equivalent. Total number of patients were 663, which included 397 females and 333 right eye within an age range of 45 to 80. The mean axial length was 23.24 and Y to weight was 11.6, and mean refractive spherical equivalent was minus 0.18 and expected refraction minus 0.32. And the normal axial lengths were more prevalent compared to the Holiday schema, and eyes with shorter and longer axial lengths were significantly less prevalent in our study, and eyes with normal and small anterior segment geometry were more prevalent, while eyes with large anterior segments were significantly less prevalent compared to Holiday schema. The axial length in ascending order is nanophthalmos, hyperopes, microphthalmos, normal, megalophthalmos, and myopes. The order is switched for white to white, with microphthalmos smaller than hyperopes and myopes smaller than megalophthalmos, and these are expected differences as the groups are defined according to these parameters. The anterior chamber depth shows statistically significant differences among the subgroups, which increases in proportion to the axial length, except for megalophthalmos, whose anterior chamber depth is smaller than normals. Lens thickness does not show statistically significant differences among the groups, and nanophthalmic eyes have the second thickest lenses, which needs to be taken in the context of this because the ACD and axial length is shorter. The Bland-Altman plots the differences. Bland-Altman plots the differences between a pair against the mean of the pair of measures, and we have plotted the mean of expected and achieved on x-axis versus difference between expected and achieved MRSC on the y-axis. The mean difference is only minus 0.12 diopter, and a constant optimization is not recommended because systematic and proportional differences are nil. Similarly, in axial myopia, a constant optimization was not recommended as the mean difference is only minus 0.04 diopter. Though the slope indicates a positive correlation, a constant optimization was not recommended as systematic and proportional differences were not statistically significant. In axial hyperopia, the mean difference is minus 0.2 diopter. Statistically significant systematic differences are noted, which means that both differ at least by a constant amount, and this can be corrected by adjusting the A constant or lens factor. The outcomes are more myopic than expected, hence we need to alter the A constant by the amount of mean difference. And relative anterior microphthalmos, the mean difference is minus 0.24 diopter. A constant optimization is not recommended due to significant systematic and proportional bias. In positive slope, there is a direct correlation between the means and the difference between the means. In eyes with normal axial length with normal anterior segment geometry, the mean difference is minus 0.14 diopter. A constant optimization is not recommended due to statistically significant systematic and proportional differences. The negative slope indicates that there is an inverse correlation between the means and the difference between the means. So the limitation is it's not adequately powered for the subgroup analysis for all the holiday subtypes and for all the IOL models. And the conclusion, to conclude, the study indicates that holiday subgroups with minimal mean differences and insignificant systematic and proportional bias do not need a constant optimization, that is in nanophthalmos and axial myopes, and groups with only systematic bias and no proportional bias can have better refractive outcomes by a constant optimization as in axial hyperopes, and factors other than a constant optimization need to be considered in subgroups with both systematic and proportional bias to improve the refractive outcomes. Thank you.
Thank you.